Good evening, dear college and dear doctor. Thanks for inviting me. My name is Dr. Marcio Civico. It's a great pleasure and honor to be here. And today I'm going to talk about an article titled Gender and Outcomes in Non-Small Cell Lung Cancer. It's an all prognostic variable returning for target therapy and immunotherapy. Um, and we and I will start. I will start. Next. Um, Starting with the introduction, we have these four important points, no? And the first point, lung cancer is responsible for 1.6 million of deaths every year, where tobacco smoking is the main risk factor, no? The difference is response to treatment and outcomes could be related also to a differential distribution of clinical pathology features. For example, smoking status, histology, EGFR mutations, and so on. And the third point, as gender influence innate and adaptive immunological difference could be behind the difference in outcomes observed in some malignant disease. And last point, some therapeutic strategies involve manipulating the immune system, while the immune system per se helps to model cancer evolution, determining difference in tumor aggressives and response to treatment. No? Next, please. Regarding the methods used, it is mainly based on meta-analysis, beginning with meta-analysis for gender difference in OS, and we retrieve information from 67 published records, of which 12 were eligible for data extractions. Meta-analysis of EGFR tyrosine kinase inhibitors. In total, 6 phase 3 clinical trials testing EGFR tyrosine kinase inhibitor or TKI versus chemotherapy in patients with NSCLC with the EGFR mutation were identified, evaluating gefitinib or erlotinib or afatinib. The next meta-analysis of ALK inhibitors in the total 4 phase 3 randomized trials comparing ALK inhibitors versus chemotherapy in patients with NSCLC, whose tumors varied ALK. Regimens were identified and evaluated. 2 trials evaluated cernitinib and 2 crenotisib. 2 trials were in the first-line treatment of metastatic or recurrent NSCLC. 2 trials in second-line treatment in patients who had received one prior platinum-based regimen of previously exposed to crizotinib and platinum-based doublet chemotherapy. A last meta-analysis is of anti-PD-1 inhibitors. We evaluated 5 randomized phase 3 studies comparing anti-PD-1 inhibitors versus chemotherapy, including 2 studies with pembrolizumab versus chemotherapy and 2 with nivolumab versus chemotherapy. Next, please. And then we have the following results. First, we will see improve of OS in female patients in data for the routine setting. In total, 7 studies for OS multivariate analysis were identified. In the meta-analysis with the random effects methods and HR saying 0.73 was obtained favoring female patients, no? With high statistical heterogeneity between cohorts, with confidence, with interval confidence of 95%, no? In this figure 1, meta-analysis of the effect of gender in the overall survival comparing HR and and 95% say obtain for multivariate analysis in hospital databases. Next, please. Effect of gender in the benefit from targeted therapy and immunotherapy in terms of PFS. And we see anti-EGFR takes in the total 931 female and 494 male patients were evaluated in 6 phase 3 trials. The meta-analysis in male patients showed an HR saying 0.44, favoring EGFR inhibitors. There was no observed significant heterogeneity between cohorts. No, when women were evaluated, and the meta-analysis showed a HR saying 0.34 with high heterogeneity between cohorts, no, with the interval confidence of 95%. Next, please. Effect of gender in the benefit from target therapy and immunotherapy in terms of PFEs. We have anti-EGFR takes. In the meta-analysis in the female cohort, there was observed a publication bias in the optimal study. No, anti-PD-1 inhibitors for all studies. 1,028 female and 1,435 male patients were evaluated. In male patients, it was observed an overall age same 0.76, favoring anti-PD inhibitors with significant heterogeneity between studies. For female patients, there were no clear benefits seen for nivolumab or pembrolizumab when compared with chemotherapy. And there was no significantly heterogeneity between the cohorts. Next, please. Effects of gender in the benefit target therapy and immunotherapy in terms of PFS, anti-ALK inhibitors. The analysis in the cohort of female patients showed an HR saying 0.51, favoring ALK inhibitors. In this evaluation, there was no heterogeneity between trials. In addition, there was no observed publication bias. Next, please. Continuing with the discussions, we have two. There is a well-known fact that women have better outcomes than men in the several cancers. The risk of death for cancer is 1.6 times higher in male than in female patients. No, in the data, the meta-analysis with random effects shows a 27% reduction in the risk of death in female patients. 6 trials evaluating EGFR takes showed a 10% reduction in the risk of progression. No, with HR saying 0.44 versus 0.34 for men and women respectively. In this analysis, because all patients have sensitive sign mutation in EGFR, the treatment was given in the first line and the comparison group was chemotherapy. Next, please. The main bias is that several risk factors could have a different distributions between genders. And the evaluation of various cancers showed that only 15% of women have a higher mutational load in contrast to male patients with 31.2%. Immunity promotes tumor progression, and since women have a different immune response than men, it could also shape distinctive biology between the genders. For example, a lower mutational burden. In a recent report evaluating patients with melanoma, female Gardner was significantly associated with a lower likelihood of response to anti-PD-1 inhibitors. Next. And finally, we have the following conclusions. We have 4 conclusions of this article. And the first point is this exploratory study, some targeted treatments were influenced by gender despite difference in outcomes that could be attributed to different histology, EGFR, and smoking status. Gender should be evaluated more deeply as prognostic variable in the patient with NSCLC. And 2 point, precision medicine has put in the mind of oncologists the genomics as the axis of drugs prescriptions. However, there are classic prognostic variables that can be taken into consideration for precision medicine. 3 point, gender is one of the oldest prognostic variables in oncology that is being more and more time left behind in the current research. And finally, gender should be analyzed deeply in current trials because biological difference called compromise response to target drugs. And thanks for inviting. Thanks for attention.